At this time, I would like to introduce our first speaker, Dr. Greg Cooper. Dr. Cooper is a behavioral neurologist at the Norton Neuroscience Institute in Louisville, Kentucky, where he serves as Chief of Adult Neurology and Director of the Memory Center. He earned his PhD in 1992 and his MD in 1994 from the University of Kentucky, followed by residency and fellowship training at the University of Iowa Hospitals and Clinics. After briefly directing the Memory Disorders Clinic at Iowa, he joined the Sanders Brown Center on Aging at the University of Kentucky before moving to Norton Neuroscience Institute in 2021. In addition to his clinical practice, he has led numerous clinical trials in Alzheimer's disease and authored many manuscripts and chapters. Welcome, Dr. Cooper.
Thank you very much, Hoy. And we will make sure that I can share appropriately here. So I appreciate everybody joining us today. My topic is the evaluation and treatment of Alzheimer's disease and really updates in that field. A few disclosures that I want to give. I or the institution has research support from Eli Lilly, ASI, and Davos Alzheimer's Collaborative. So as a general outline today, I'm going to give some very brief background, some definitions, et cetera, about Alzheimer's disease and dementia. We're going to talk about the diagnostic evaluation and give some updates on the evolving role of biomarkers. And then we'll talk about treatment, really focusing on the newest class of medications, anti-amyloid therapies. So first, for some background, I think it's useful to think of a couple broad definitions. First is mild cognitive impairment, and that's really a description more than anything else, and it means that someone has an impairment in one or multiple spheres of cognition. That may very often be memory, recent memory. It may be language, difficulty coming up with words, difficulty communicating. It may be attention. It may be executive function, our ability to plan or organize. But the point is, if I have mild cognitive impairment, I have some impairment in cognition that is beyond what I can say is normal for age, but it is not to the degree that it's significantly impairing my day-to-day functions. It doesn't mean it has no impact, but I'm still able to carry on independently. That may or may not lead into the next category, dementia. Now, think of dementia, again, as a broad term, a broad umbrella term, meaning there are impairments now in multiple spheres of cognition, memory, language, orientation, executive function. And now it is to the degree that it is significantly impairing my day-to-day function. Now I do need my family to help manage my medications, my finances, my meals, my day-to-day function. There are a long list of potential causes for dementia, but for the most part, they fall under these four main categories. So Alzheimer's disease, most common cause, marked by impairments in memory, particularly recent short-term memory. And then there's vascular dementia. And as the name implies, it's associated with cerebrovascular disease. Often with that also, we'll see kind of a dysexecutive syndrome, slowed cognition. I may get to the right solution, but it takes me longer to get there. Everything's slowed down. And then there's dementia with Lewy bodies, and that, in a sense, overlaps with Parkinson's disease. We may see physical symptoms of Parkinsonism like slowness, stiffness, trouble with balance, trouble with ambulation. We also will often see marked fluctuations, and we will often see early on hallucinations, particularly well-formed visual hallucinations. And then the last category has multiple categories under it, in fact, frontotemporal dementia. And I'll just briefly say that may be marked by prominent personality changes. It may be marked by prominent changes in language. Now, we're really focusing on Alzheimer's disease to a great degree. Alzheimer's disease is far and away the most common cause of dementia. It accounts for 60 to 80% of all cases of dementia. Around 7 million people in the US currently have Alzheimer's disease, and that's expected to double in the next couple decades. Again, it's the most common form of dementia. It's an insidiously progressive illness that typically plays out over 8 to 10 years. Initial symptoms, difficulty recalling recent events. It might be thought of as a disorder of learning, of forming new memories. So early on, someone with Alzheimer's disease may remember events from 20 years ago better than I do, but they have trouble remembering a conversation they had earlier in the day. They have trouble laying down those new memories. And kind of along those lines, misplace objects. I forget where I put something. I'll repeat myself because I don't remember the answer you just gave me. So again, a problem with learning, a problem with recent memory. But then over time, we'll see other symptoms, disorientation. Now, when we think of disorientation to date or time, that's really a problem with memory. But we may also have visuospatial disorientation. In other words, difficulty navigating from point A to point B. We may have language problems. Early on, we often see problems with word finding. Can't quite come up with the right word. We may make paraphasias, a near miss, not quite the right word, but close. We may have a dysexecutive syndrome. Executive function, again, is that ability to plan, to organize, perhaps to have good judgment. So if I have Alzheimer's disease, my judgment is not as good, and I'm more easily taken advantage of. I'm more easily scammed. And we'll often see social disengagement. Now, pathologically, and this will be important as we go deeper into the talk, we see two hallmarks, amyloid plaques, so plaques of this sticky protein called amyloid or beta amyloid, and neurofibrillary tangles, that's made up of another protein called phosphorylated tau, or just think of tau. So when we think of pathology, think of plaques and tangles, think of amyloid and tau, and that'll come up later. Now, let's talk about how we evaluate dementia. Well, by and large, this is still old-fashioned medicine. It largely comes down to the history, talking to someone. Yeah, we always, of course, talk to the person that's involved, but when we're worried about memory disorders, it's critical that we talk to an informant. Uh, this may sound a little facetious to say, but if somebody comes into my office and says they think they have Alzheimer's disease, 9 times out of 10, they do not. On the other hand, if someone comes into the office and says, I think I'm doing perfectly well, but my family is worried, that's when I'm much more worried. Most of the time, if we have a disorder of memory ourselves, we are not going to have the same insight. We're not going to have the same awareness. We're not going to remember what we didn't remember. So we really need to rely on an informant, a family member, a loved one. We want to ask, when did this begin? Realizing that with most conditions like Alzheimer's disease, you can't put a single date on that. But has it begun over the last year, 2 years, 3 years? How did it begin? What were the initial symptoms? Was it problems with memory, or was it something completely different? Did it come on suddenly, or did it gradually come on over time? And then how has it changed over time? What other symptoms have come on? And 90% of the time, after you've taken a careful history, you already know the answer. So most of it comes in that history. We do a neurologic exam. That is really to look for clues of other conditions like vascular disease or stroke or Parkinson's disease or some other medical disorder. If someone has Alzheimer's disease, the neurologic examination, the basic neurologic examination is typically going to be pretty normal and really only take minutes to do. And then we want to do some form of cognitive testing. We want to test memory. We want to test language. We want to test attention, executive function. And that can often be done surprisingly quickly. We often use some standardized test like the Mini Mental State Exam or MMSE or the Montreal Cognitive Assessment or the MoCA. And there are other things we may add to that. But for most folks, we can get the information we need off of a fairly simple standardized test like that. And then we'll move on to laboratory testing. And the minimum testing is usually a vitamin B12 level. I often add a folic acid or folate level and a thyroid function test like a TSH. Certainly, we can do other testings in the appropriate situation if there's reason to be suspicious, we might look at syphilis or HIV, or we might look more carefully at other tests. But the bare minimum would be a B12 and a TSH. And then we'll want to do some type of imaging of the brain. We prefer to do an MRI, but certainly we can very often get the information that we need from a CAT scan. But at a minimum, we want to do some structural image of the brain. I'll talk more about that in a minute. In select cases, we'll do neuropsychological testing. This is very involved, detailed memory testing that can take an hour up to 3 or 4 hours. It's not necessary all the time, but in some situations where the answer is not clear, it can be extremely useful. More and more often, we are doing spinal fluid testing. Now, that really takes us into the area of biomarker testing, and I'm going to hold on that for right now. We'll talk a bit more about the emergence of biomarkers shortly. Now, when we think of imaging, neuroimaging, it is useful to think about the three different ways it can be used. It can be used structurally. So in this case, by and large, we're ruling out things like stroke or tumor. We may be looking for areas of focal atrophy, parts of the brain that are atrophied much more than other parts that might point us to a particular diagnosis. And then there's functional imaging. Now, this really, for practical purposes, comes down to something called FDG PET. It's a PET scan, and FDG is fluorodeoxyglucose. It's looking at metabolism in the brain. And there are certain conditions, for instance, frontotemporal degeneration or dementia will show marked hypometabolism in the front part of the brain. There's a particular profile that might be seen in Alzheimer's disease. It's very different from that. So functional imaging can give us an idea of how the brain is actually functioning and help us with that. And then there's molecular imaging. Again, this is pulling us back to the area of biomarker testing. Molecular imaging is looking at particular molecules, or in this case, proteins, amyloid and tau in the brain. And you remember me telling you in Alzheimer's disease, the pathology, amyloid plaques, so amyloid, neurofibrillary tangles, tau. And we now have scans that can help us look at that. Well, I'm just going to show you in a couple of examples of what we might see on a structural image. So this is someone who may well have had a normal neurological exam, but have significant memory problems. They have a meningioma. It's a benign tumor, but in a sense, maybe not so benign that it's causing significant symptoms. We discover that, we remove the tumor. The memory problems may not entirely reverse, but it certainly improves. That's an important condition you would not want to miss. In this case, this is someone who would have had the sudden onset of memory problems. Wouldn't have come on gradually over months or a year, but on a single day at a single hour, they suddenly develop memory problems. And really look at the area marked by the yellow arrow. That is a stroke in the hippocampus, a part of the brain that's involved in forming memories, and coincidentally, the same part of the brain that's involved in Alzheimer's disease. And then this is a little bit more of a difficult scan. This scan shows a lot of vascular changes. So those puffy white areas all throughout the brain are thought to be an indication of underlying vascular disease. Perhaps not a discrete stroke, but more of a progressive atherosclerotic state, you might say. That is tricky because if you see that, it would certainly raise concerns that someone has underlying vascular cognitive impairment, that could be a reason for their memory problems. It is tricky because someone could have an MRI like that, and we may not detect any memory problems on their exam. So it does not prove a condition, but it certainly correlates or would suggest that vascular disease may be the cause of their memory problems. Now, I'm finally going to dig into the issue of biomarkers. So biomarkers, for the purposes of Alzheimer's disease, really means studying some kind of marker, very often a protein in the brain and some bodily fluid that can help us detect underlying pathology like Alzheimer's disease. Now, this has been around for 20 plus years, but it's really starting to come of age. In 2018, the NIA and Alzheimer's Association released a research framework that is coming into more and more clinical practice called the ATN model. Now, A means amyloid, T means tau. We talked about those proteins and the pathology of Alzheimer's disease, and N means neurodegeneration. And according to this criteria, if we find evidence of A plus, and T, tau, T plus, A plus, T plus equals Alzheimer's disease. So how can we detect those? Well, for amyloid, we could do it by a PET scan, an amyloid PET scan. I'll show you a picture of that in a minute. We can do it through spinal fluid, looking for levels of amyloid. There are now serum or blood-based biomarkers. Now, almost counterintuitively, the best biomarker for amyloid is p-tau 217. So you would think, well, tau, that's not amyloid, but in fact, that correlates best with amyloid. So we have some pretty good markers for amyloid. What about tau? Well, there is a way to do a PET scan looking for tau, but that's not in clinical use right now. That's in research. So that's promising, but not very helpful for us today. Spinal fluid, again, that tends to be our preferred way to look for these biomarkers so we can see evidence for tau. And then there is a new serum biomarker, which I don't believe is available, but something really for us to keep our eyes on. MTBR tau 243. I don't think you need to remember this alphabet soup. The point is we've got promising blood-based markers, blood-based biomarkers that are now available and more coming online. And then to look for neurodegeneration, you can do an MRI and just show there's atrophy of the brain, or there are other markers in the spinal fluid that you could show evidence of neurodegeneration. And those are useful, but probably less germane to our talk today. So here's what an amyloid PET scan looks like. So on the left is someone that does not have amyloid. And we refer to these as nice, cool colors. You see blues and purples around the outer edge of the brain, meaning there's not amyloid that's lighting up. On the right side, you see bright colors like orange and red. That tells us that there is amyloid in the cortex, that outer rim of the brain. So that would be amyloid positive. And that would be an indication that in the correct clinical setting, this person likely has Alzheimer's disease. Now, that's a PET scan, and the main drawback to amyloid PET is that it's not readily available, but that's improving. The preferred biomarker right now is spinal fluid, and there are a lot of different measurements that get taken and different ratios that can be done. When you see A beta, that's amyloid, and there are different types of A beta. So one of the measures that people like is A beta 40 to A beta 42 ratio. And then another one that is a very good test is the p-tau 181 to A beta 42 ratio. And again, these are not things we all need to necessarily keep in mind, but there are different packages or different products that labs will provide, and the ones that are generally considered the best are those top two. Now, let me go into blood-based biomarkers because I think this is the future. There is debate whether it's the present or not, but it is clearly the future. And there are a number of blood-based biomarkers that we can get. So there are a number of these A beta, so different amyloid species or ratios that we can get. And they're all fair, really, not great, but fair. And then there are different types of p-tau or tau that we can look at. And I put in bold the one that really probably far and away shows the best performance, p-tau 217. But again, counterintuitively, that is a marker of amyloid, but it correlates very well with what we might see on a PET scan or an MRI scan. And you can look at NFL, neurofilament light chain. That is really a marker of degeneration. So it is not specific to one condition or another. So the point is there are a lot of blood-based biomarkers, and some are fair and some are good. They're not all equal. And so you want to keep that in mind if you were to ever order any of these. So if we want to kind of summarize this or look at our current state, still CSF, spinal fluid, is the gold standard, but it's a pretty tight race. Amyloid PET is probably comparable. It can be difficult to either get the scan or just get insurance coverage for it. But that's probably a pretty comparable test to do. And then there are blood-based biomarkers, and some are pretty comparable to spinal fluid, and some simply are not. And an important point, interpretation of the results depends very much on the pretest probability. And this may sound like I'm oversimplifying it, but if someone has a history and an exam that is typical of Alzheimer's disease and they have a positive test, they probably have Alzheimer's disease. If they have a negative test, there's a pretty good chance that was a false negative, so it shouldn't rule it out. Just the opposite is true. If someone really doesn't have a history and exam typical of Alzheimer's disease, a negative test pretty well rules it out, but a positive test does not rule it in. So you have to be very careful in how you interpret these tests, and it has to be done in combination with the history of the exam, the clinical suspicion. And every society and every expert seems to agree these tests should not be done without some real objective evidence for cognitive impairment. And the reason being, we just don't know how to interpret these tests yet. All right, so let me move on to the last part here. I want to talk about management of dementia. Now, there are a lot of ways we can divide this up, and I've divided it into two very broad categories here. So we have cognitive enhancers. These are medications that, as the name implies, they just simply help support brain function. They improve cognition in general. So you have the cholinergic medicines. These are medicines like donepezil, rivastigmine, galantamine. They've been around for over 20 years. They all work in essentially the same way. They are cholinesterase inhibitors. They block the breakdown of acetylcholine. So you have more of this neurotransmitter floating around in the brain, which allows our synapses, our neurons, to communicate more effectively, and that helps support cognition. And then we have memantine. It's in its own category, and it works on the glutamatergic system, but in a somewhat analogous way. It helps with that communication between neurons that use glutamate as a neurotransmitter. And they are all modestly effective. They treat the symptoms. They're not treating the underlying pathology, but they treat the symptoms. And most people would argue everybody deserves at least consideration of these medications, and they've been helpful for a long time. Now, in the last couple of years, we've moved into a new era. We, for the first time, have disease-modifying therapies, therapies that are trying to treat the underlying, or at least one of the underlying causes of Alzheimer's disease, amyloid. So these are anti-amyloid therapies. And currently we have two on the market, lecanemab and donanemab. So if we get into that a little bit more, it's important to understand the amyloid hypothesis. Why do we think an anti-amyloid therapy would do anything? Well, the amyloid hypothesis states this. It states that it's the deposition of beta amyloid in the brain that is a key pathogenic trigger in a long and complex cascade that ultimately leads to clinical Alzheimer's disease. So, in other words, we are saying if this hypothesis is true, the deposition of amyloid is a root cause. Well, what does that look like in the brain? So, we all have a large protein in the brain. It actually goes from inside the neuron, the brain cell, across the membrane to the outside. It's called the amyloid precursor protein. And so if you look at that top panel, that's the long squiggly thing is the amyloid precursor protein. Now it has some normal function that has not entirely been worked out, and it's not just in the brain, it's throughout our bodies. When it gets metabolized in a particular way by secretases, particularly a beta secretase and a gamma secretase, it releases this small fragment that you can see in that lower left-hand panel, that little golden fragment. That's beta amyloid. So that's, in a sense, the problem. Well, we're all doing that right now. That's happening to all of us. And that's okay. If we release that in small volumes, our brain clears it out of the way, kind of the waste matter of the brain. Maybe not a big deal. But If we either start making too much or we're not clearing it out appropriately, it starts to clump together. First in what are called oligomers and ultimately in plaques. And that's what you can see in that right side, right lower panel. We're in a sense precipitating out these beta amyloid plaques. And that's where the problem really starts, when it starts to stick together. So uh, we as a field have been working on anti-amyloid therapies just about as long as I've been in the field, starting, I think, even pre-2000. And finally, in 2023, we had approval of the first of these medications that's currently on the market called lecanemab. Now, I got an accelerated approval in January 6th, but more importantly, got a full approval by the FDA in July of 2023, and immediately thereafter, CMS Medicare provided a coverage determination, making this medication available to patients generally. And then donanemab, related medication, received full approval about a year later in July of 2024. Now, these are both monoclonal antibodies, meaning antibodies created in the laboratory that target particular types of beta amyloid. And in essence, then using the immune system to clear these proteins out of the brain. Lecanemab targets the protofibrils. That means the little fragments of amyloid just when they're starting to stick together. Donanemab targets the more mature amyloid plaques when they've already clumped together. And whether that distinction is important or not is debated, but the point is they both target beta amyloid and they both target slightly different phases of that process. Now, if we look at lecanemab, and this is just one slide from their main study that led to FDA approval, we see a slowing of the decline. So this medicine does not reverse memory loss. It's not a cure for memory loss. But if you look at the blue bar, which is placebo, compared to the gold bar, lecanemab, you can see that those bars start to separate pretty early on. We have a slow decline with lecanemab. And it may be a little bit hard to see in this slide, but it is believed that the slope of that line has changed as well. You see something similar with the donanemab, although I'll point out something a little bit different here, but they're the same thing. In this case, they're black and green bars, but if patients that were treated with donanemab, you saw a clear difference favoring those that were on donanemab, a slowing of that decline if they were on donanemab. They did something interesting in their particular, they did a couple things interesting in their trial that are intriguing, and I don't think we fully understand the importance of it yet. They divided their patients into low, medium tau, and then just everybody combined. And the thought would be people that have a low or medium amount of tau are earlier in the disease process than people that have a higher burden of tau, again, these neurofibrillary tangles. And they showed if you just looked at the people in that low, medium tau population, they had a bigger effect than people that maybe we picked up later in the disease. So the idea there is it is possible the earlier we start these medications, the more effective they're going to be. In a sense, it might be a rationale to say time is brain, maybe not on the scale of stroke, but certainly there might be a push to start these medications earlier. The other thing, I don't think it's well shown in here, but in their particular study, they allowed people to stop treatment after, by PET scan, they were amyloid negative. Once they'd cleared out all the amyloid, the rationale was we no longer need this medication. And yet, even after stopping the medication, the distance between placebo and treatment continued to widen. In other words, patients who were on the treatment, even if it was for just 6 months or a year, continued to accrue benefit after they had stopped the medication. Now, there are potential problems with these medications. One is the treatment burden. These are not simple pills that we can give somebody to take home. They require infusion, so they have to come to an infusion center, lecanemabs every 2 weeks, donanemabs once a month. They have to have frequent MRI scans, and the MRI scans are because of the next problem that we worry about. The primary side effect we worry about is something called ARIA. ARIA stands for amyloid-related imaging abnormality, and that can come as ARIA-E, E meaning edema, swelling, or ARIA-H, H meaning hemorrhage. Now, this slide shows that somewhat. If you look top left panel under B, where those arrows are, that's a small area of swelling in the brain. Likely wouldn't have caused the patient any symptoms, but we would pick that up on an MRI. That would be an indication of an inflammatory response to the treatment, and it would tell us we either need to monitor very carefully or possibly even stop therapy. And then H, the bottom right panel where you see the circle, those little tiny dots you can see almost look like grains of pepper. Those are micro hemorrhages. Those are truly microscopic areas of bleeding. We see them on a specific MRI because of a blooming artifact. But the important thing is they're showing evidence of bleeding, which again might be a marker of inflammation of those blood vessel walls and an indication that this individual may be at risk for more serious problems down the road. And in fact, you can have a macro hemorrhage. People can have large areas of hemorrhage in the brain related to these treatments. So they're not without their risk. Now, fortunately, most people that have ARIA don't have symptoms related to this, but some do. And the symptoms you might expect: headache, confusion, visual changes, dizziness, nausea, may have gait impairment. So all of those are potential well-known symptoms. It can be serious to the degree that someone would need to go into the hospital. So seizure, SE stands for status epilepticus. So in a severe case, someone might have status epilepticus, encephalopathy, stupor, focal neurologic symptoms. It may mimic a stroke. So in some cases, now fortunately, less than 1% of the time, this can be severe. Someone would need to go into the hospital and can even be life-threatening. So there are certainly good and bad to these medications. Who would be eligible in practice? Uh, Primarily early people who are early on that have mild cognitive impairment due to Alzheimer's disease, so evidence of underlying amyloid, or mild Alzheimer's disease. And to think of it very broadly, the criteria that are published for lecanemab, a mini-mental state score of 22 or above, or at donanemab, a score of 20 or above. So, very broadly thinking, mild symptoms in the range of a mini-mental of 20 to 22 or above. The generally recommended age range is 50 to 90. And of course, there has to be the presence of pathological amyloid. I know it always sounds silly to say this, but there would be no reason to remove something that's not there. So if you're going to have an anti-amyloid therapy, we need to know there's amyloid. We typically do that by a spinal fluid exam. We are probably going to do more PET scans in the future. And certainly blood-based biomarkers are coming of age. I put a question mark there because while there are some that are quite good, sometimes insurance will accept those and sometimes they won't. And so patients need to be aware we may have to do a spinal fluid exam regardless of what their blood biomarker said in order to get approval for this medication. Exclusion. Well, inability to have an MRI. You have to do MRI scans to monitor this. Evidence of a arguably related condition, cerebral amyloid angiopathy. That's a condition essentially where you're already prone to brain bleeds, where you certainly don't want to give a medication that may aggravate that. More than a couple lacunar strokes or a stroke in a large major vascular territory, or severe subcortical ischemic changes. Now, I don't expect everybody to start measuring their own Physika score, but basically what this means is they have a severe degree of white matter changes on their MRI. And what that would tell us is that likely the cause of their disease that's really driving their symptoms is vascular disease, not Alzheimer's disease. So there's probably not a great benefit of starting an anti-amyloid therapy. Other exclusions, currently anticoagulant usage. Now, I should probably put that in italics. In the studies of these medications, people were on anticoagulants. And there are some individuals out there that will treat people on anticoagulants with these anti-amyloid therapies. However, the published appropriate use guidelines tend to warn against that. And again, the reason being these medicines already carry with it a risk of ARIA-H, brain hemorrhage, and we don't want to do anything that might raise that risk. Recent stroke or TIA, immunologic disease or systemic treatment with immunosuppressants, immunoglobulins, monoclonal antibodies, that may evolve over time. That's listed as an exclusion criteria, largely because we just don't know what the impact might be. Bleeding disorders. Now, history of seizures. Appropriate use guidelines might say any history of seizure at all. In the studies, it was typically a seizure within the preceding 12 months. And so I think many people will go ahead and treat somebody that has a history of seizures as long as they're well controlled. And then really any unstable medical condition. In practice, lecanemab, they're both intravenous infusions. Lecanemab is every 2 weeks. Donanemab is every 4 weeks. The infusions are similar. Lecanemab takes an hour. Donanemab takes 30 minutes. And then there are varying degrees of observation. Right now, it's generally recommended for lecanemab 3 hours after the first infusion, a couple hours after the second, 30 minutes thereafter. With donanemab, it's simply a 30-minute infusion. I think we are learning with experience that there are a number of people that may have a delayed infusion reaction. Everything looks good, they go home, and then they might develop chills or malaise that evening. And that's something we're watching. By and large, that has not been a major problem. Monitoring, as I've alluded to a couple times, we have to do frequent MRI scans. Again, we're watching for evidence of ARIA. And then if anybody has just symptoms that could possibly be an indication of ARIA, we do an additional MRI in addition to these that are already scheduled. Now, it's generally thought once you get through the first 3 to 4 or at least 6 months of therapy, you're through that main window of risk for ARIA, so everybody relaxes a little bit and we don't have to do as much monitoring. But early on, we take that very seriously. We need to do a lot of monitoring. If somebody has mild ARIA on an MRI but no symptoms, we can continue the dosing. We just have to repeat an MRI every month until it resolves or stabilizes. But if it's moderate or severe on the MRI or they have symptoms, then we will stop treatment. We will repeat an MRI again in a month, watching for resolution or stabilization, and we can consider restarting in the future. Now, we have two agents. How do you compare them? And the truth is, it is difficult to compare them directly. They were in different populations. They used different outcome measures. There is not a head-to-head trial to tell us. But there might be some clues. Both studies use something called a CDR sum of boxes. CDR is a clinical dementia rating scale. It's kind of a global scale of dementia, and the sum of boxes is just kind of the broad measure out of that. And with lecanemab, it showed it slowed things by about 27%. With donanemab, it slowed things by about 29%. Now, I should point out here, they all had multiple outcome measures that would generally show slowing of progression somewhere in the 20s to upper 30s%. We generally tell people it slows disease down by about 30%. But for the sake of comparison, this was the one measure they had in common, and arguably it's pretty comparable. If you look at ARIA, so any ARIA, MRI evidence of ARIA, symptoms or not, lecanemab about 1 in 5 patients have some evidence of ARIA. With donanemab, it's a little over a third. Symptomatic ARIA, meaning I have symptoms like headache, nausea, vision changes, confusion. Just about 3% with lecanemab, just about 6% with donanemab. So a bit higher with donanemab. And I won't go into the details here, but we will typically do a genetic test, ApoE status. We do that to risk stratify people. So the fewer copies of the E4 allele, the safer we are, the more copies of the E4, the higher our risk is. So, for example, if we just look at symptomatic ARIA-E, if I'm homozygous, if I have two copies of the E4 allele, my risk is about 9% with lecanemab, about 8% with donanemab, though with donanemab, the risk of asymptomatic was a bit higher. Now, I'm wrapping up here. This is kind of how things have looked over my career. So the dotted blue line is the course of Alzheimer's disease with no treatment. The dashed yellow line is with the introduction of cholinesterase inhibitors like donepezil. So we pushed things over a bit. We added memantine, that's the blue line. We pushed things over a little bit more. And now and I'm sorry, I should have updated the slide, lecanemab or donanemab, just anti-amyloid therapies, we're changing the slope of the curve. We're trying to turn this into a more manageable chronic disease. We're obviously not there yet, but that's kind of the evolution of treatment, and hopefully we'll see researchers continue to build on this. So, as a summary, Alzheimer's disease is common. Biomarkers can certainly help with the diagnosis, but not all biomarkers are equal, and they shouldn't be used in the absence of cognitive impairment. They're a powerful tool, but they have to be used correctly. And then anti-amyloid therapies, we are there now. These are available. It certainly slows progression in eligible patients. It's not a cure, but it's significant. ARIA is a potentially serious adverse effect, and we need to monitor for that. And that tells me that I am done with my slides. I think we have, Hoy, maybe 5 minutes for questions. I'm not sure of the time. I apologize.
No, you have about right. While we're waiting for questions to roll in, I have a couple. What tests would you recommend be started in primary care before we send on patients to to a specialist?
So I think there are a couple ways to answer that. I will tell you, just personally, it doesn't bother me if no tests are done. If it's easier just to send to me, that's fine. But I think what the primary care physician or provider really wants to do is check a B12. I would add a folate, but a B12 and a TSH, a thyroid test. And I think it is a good idea to try to get an MRI scan. The one caveat I'll throw there is if there's a chance that someone might be a candidate for an anti-amyloid therapy, you'd want to talk to your radiologist and make sure they do a heme-sensitive sequence, meaning either an echo or a susceptibility-weighted imaging, so that they can show it might need to be repeated in the future. I think that's a minor point, but those would be the tests I would be thinking about.
And for some of us, we may not have access to specialty services. How much testing do we really need to do to arrive at a diagnosis?
Well, I think if someone is comfortable with a condition like this, I believe it's almost all in the history and the exam. And if you do a B12, a TSH, and an MRI or even a CAT scan, and those look normal or essentially normal, and the exam and history fit, I think that's enough, honestly. I believe that most people can make these diagnoses without a lot of advanced testing. The advanced testing, I don't want to diminish the importance of it. It can be very helpful in uncertain cases, but at least in my experience, 90% of the time, it's not that complicated, and you're going to arrive at the right diagnosis already.
Alrighty. We do have a question from in the chat from a participant. Could there be benefit for someone in a more moderate stage for an anti-amyloid therapy? And the comment is, I think some benefit would be possible. Also, is there benefit to being on something like Aricept or Namenda along with an anti-amyloid?
So the second question is actually the easier one. There is definite benefit from being on Aricept, Namenda plus an anti-amyloid. No reason you would just do one or the other. The first question is harder. And the most honest answer is we don't know if there's benefit in moderate disease because we haven't tested it. There is a lot of reason to speculate based on older trials that there probably isn't a benefit. That if we're going to intervene with an anti-amyloid therapy, it needs to be early on. If we wait too long, we've lost that window. So the answer is probably not, but I hope someday someone proves me wrong.
Okay. Just before that question, when you were talking about radiologist, the sound kind of got distorted. And could you repeat what you said when we were talking about necessary testing?
Sure, sure. So if someone is potentially a candidate for anti-amyloid therapy, and maybe just for anyone, it is helpful if you're getting an MRI to make sure your radiologist does a susceptibility weighted image. This is a sequence that looks for evidence of prior bleeding, and that can help us with the diagnosis in general, but it's critical when we're evaluating someone's eligibility for anti-amyloid therapies.
Alrighty. And one last question. How does the presence of the suspect ApoE gene affect clinical decision making for use of either of these medications given the lifespan of persons with late onset AD?
So
Seems
that's
maybe.
really a Yeah, no, that's a great question. Uh, the the way that I use it is simply to stratify risk, tell patients, their families, these are your risks, and then try to, I help them, but try to let that be their decision. What's their risk tolerance? Now, there are groups around the country who will say if you're ApoE4 homozygous, if you have two copies, we are making the decision that your risk is too high and we will not treat you with those medications. And I'm not faulting them for doing that. It is reasonable to look at it and say, well, there's a threshold, whatever that might be, and the risk is too high now. It offsets the benefits. I use that to try to inform patients and let them make the decision. But there are other people that would use that as an exclusionary criteria.
Alrighty. Thank you, Dr. Cooper, for your presentation.
All right. Well, thank you all very much. Have a great rest of the day.